Good evening, everyone. This is Dr. Faisal Al-Ghamdi, and I would like to thank everyone for being with us this evening. And it is my pleasure to start introducing uh, Prof. Muhammad Arafa, who's gonna basically teach us about understanding the importance of LDL cholesterol in clinical dyslipidemia management. And I would like to thank, so basically this webinar is under the umbrella of Saudi Heart Association. And I would like to thank Kunuz Ritaj, the organizing company, and Sanofi for make this webinar possible for us to teach and learn. I should say that Prof. Muhammad Arafa, he was my professor at King Saud University, and it is really my pleasure to be with him this evening. He's a professor of cardiac sciences currently in the Dalla Hospital, and he's a senior consultant interventional cardiology. So please, Prof. Muhammad Arafa, feel free to start. And thank you
السلام
for.
عليكم ورحمة الله وبركاته وكل عام وانتم بخير إن شاء الله. I would like to thank Dr. Faisal for his nice introduction. Thank Saudi Heart for their kind invitation and Knut Retard as well, the Sanofi company for their support of this meeting. Actually, the cholesterol theme is a very important one that we are having our daily practice now with this issue that patient come is asked about it, what should we do? And we have a lot of things to be discussing. Hopefully we have some time for discussion. So my theme was just to discuss with you the importance of LDL cholesterol. And as you know, the cardiovascular disease is really worldwide, is very common, and in our area is more really common than others. So we have to really start to think about why we have much heart disease and how we can prevent them. If you look at the ischemic heart disease, look almost 50% of the cardiovascular disease compared to the others. The majority of our patients come with acute coronary syndrome, non-ischemia or ischemia, and come really with really all the complications related to it. Now, if we look at the risk factors worldwide, you can see that LDL cholesterol ranked number 3 after the high systolic pressure and the dietary risk. So LDL cholesterol really is number 3 worldwide as a risk factor for the cardiovascular disease burden. And if you look at the kingdom here from the year 1990 to the year 2017, we can see that cardiovascular disease ranked number 1, and almost really 47% of the patients really come with cardiovascular disease mortality from this problem. Now, lately, the idea now, we should now think about coronary artery disease as atheroma rather than ischemia, because we want to prevent the first cardiac event. We don't want really to wait till the patient have acute coronary syndrome and come to the emergency room with acute MI, because this will change the prognosis as well as his really the rest of his life, say, profile, because it really he will have, if he had STEMI, the life will be reduced by almost 10 years. If he had non-STEMI, by 7 years. So it's better to start early and prevent the atheroma rather than wait for the atheroma to rupture and cause it. Because as expected, the incidence of this disease by the year 2050 will be more common than we have at the present time. If you can see the map here, this is the year 225. And this is the year 250. You can see that it's really coming to be more common disease in this area as time goes on. Now, let's talk about what causes problem. Now, as you know that we have the major problem is the LDL cholesterol. LDL cholesterol is really the key player in this process. And we have to mention as well the lipoprotein little a in particular. And we have to mention about the remnant cholesterol, the high triglyceride. When we talk about it, we talk about ApoB, lipoproteins containing molecules. So our target will be mainly today to talk about the LDL cholesterol. And if we have any questions about lipoprotein today, we can discuss it. Now we have so many trials from the year 1994 till currently now, discussing the issue of really the management of hypercholesterolemia. We can divide the trials into non-statin trials using the injectable forms, and we have the ilaclimab, and the other one in calciran, as well as we have the benzoic acid. And as well, we have many trials done on statins, starting from the 4S down to the IMPROVE-IT, and all of them showed that definitely we have better outcome with management, whether you use statin or non-statin, and the patient will have really better survival and less cardiovascular events when we have the lower cholesterol lowered. So regarding which management you use, whether you use statin or non-statin, at the end of the day, you have improved outcome, and the patient have lower cholesterol, and he will live better. Now, for us, we know for sure that LDL is the main cause of this problem, and this is really supported by genetic, epidemiologic, as well as trial evidence. So we have no doubt nowadays that if we do all the studies, we have proven, don't doubt, that the LDL cholesterol is the main cause of this problem. And we know that from these studies, which have been mentioned before, that if we reduce your LDL by 1 millimole, almost 39 milligram, you achieve almost 23% reduction in the incidence of cardiovascular events. The lower is the better, because the benefit is independent of the type of drug you use, and the benefit relates to the absolute LDL reduction. So when we talk about LDL reduction, we have to have two targets according to the patient risk profile, as well as the percent of reduction from the baseline. We'll talk about it in detail later. Now, the intensity of LDL lowering should be really based on the risk. The higher the risk of the patient, the more really the impact of outcome. Primary prevention, secondary prevention, diabetic, those with CKD, everyone has its own way to reduce it and improve the outcome. Now, we know for sure that as we have more exposure to the LDL from early life, we have more cardiovascular disease. Now, if we take a patient at age of 60, and we see that this is our threshold. Now, the threshold for ischemic heart disease will be reduced if you have homozygous or heterozygous familial hypercholesterolemia. So they will have their own problem with the heart attack, maybe at the age of 10, 12 years old. We have seen patients with familial hypercholesterolemia, homozygous, that they come with acute MI. If they have heterozygous familial hypercholesterolemia, it will be maybe at age 35. Without familial hypercholesterolemia, we expect it to be at the age of 55. This threshold will be lowered or higher according to the patient profile. So if we have patient who is smoking, hypertensive, diabetic, who have high triglyceride, high lipoprotein A, low HDL, he is at lower threshold bar, and he will have his acute myocardial infarction at the younger age. So the earlier the exposure, the more the disease will be there. So if we see how the thing started, we have early asymptomatic plaque, and this will really depends on the level of the cholesterol. The higher the cholesterol, the more the plaque will be there. And then what we will have, the plaque will rupture, and we have acute coronary syndrome. Our current therapy now is to wait for the patient to have his first MI and treat him, rather than try to prevent the progression of plaque. So to prevent the first attack, to prevent the first heart attack, we have to start early. We have to reduce the cholesterol as early as the teens age, according to the risk profile of the patient, to prevent later myocardial infarction. The optimal treatment should be really started in asymptomatic plaque progression, rather than waiting for plaque rupture and causing acute problems. Now, if we look at these curves here, the cumulative exposure to the LDL, we have two lines. The blue line here at the top here is the usual care we have. If you look at the dashed red line here, is the whole life prevention of disease. So if we start early, this is the risk of cardiovascular disease. If you start at age of 30, this will be your risk profile. If you start at the age of 50 or 40 or 60, the later you start, the more the risk will be. So earlier starting treatment and earlier long life really treatment will be preventing cardiovascular event by almost more than 50%. If you look at in the other side of the curve here, if you see two patients, if we start our management by the age of 40, reduction of LDL to 33% will be equivalent really or better than if you start at the age of 55 and try to reduce the LDL by 50%. So earlier start, we can achieve better target, a less target than they want really to be at higher age, and yet the patient will have less cardiovascular event. And if you look right here at the exposure, lifetime exposure, and 50% reduction of the LDL, if you reduce the LDL throughout the life and it starts really from 100, if the patient comes with 100 LDL, if you go down to 50, you reduce his risk really factor by this amount. And again, if you go start by hundreds of 90 and reduce his to low risk, the residual risk will be by reducing it to 95. And if you reach the target, you have the same level of the non-really 50% reduction. And we know for sure that the lower the better. And we have many studies who are being done before and nowadays that if you lower your LDL cholesterol to a lower level, definitely you will improve outcome of the patient. So what are the current guidelines treatment for hyperlipidemia? Again, we have to stress two facts here, that we have to have patient risk profile and reduce the level to his risk and reduce it as well together to 50%. So if your patient come with LDL of 90, you have to go down to 45. If he come with risk, any risk he require, according to his risk profile, we'll talk about it. So how about we assess the risk profile? We have the patient has been certified according to the latest guideline to 5 group. Those who have really low risk group, we can calculate the score them with a score 2 or score 2B, okay, are less than 2%. And the LDL should be here around 3, which is 116 milligram per deciliter. If you go to the moderate risk, those who have the risk score 2 or score T, all ages, all people more than 2 and less than 10%. Young patients with type 1 diabetes, less than 35. Type 2 diabetes is 50 with diabetes duration less than 10 years without any risk factors. Without any risk factors, and the diabetes less than 10 years, they are moderate risk. So the LDL should be less than 100 or 2.6. Now, if we go to high risk patients, those who have higher score, more than 10%, and less than 20, they have a markedly elevated single risk factor, their total cholesterol more than 8, or they have the LDL more than 4.9, blood pressure is quite high, familial hyperglycemia without major risk factor, moderate kidney disease, these are the high risk patients, and the LDL should be really less than 1.8 or 70. Now, if you go to very high risk patients, those who have already established cardiovascular disease, or their score more than 20, or they have familial hyperglycemia with another risk factor like they're smoking, or they have diabetes, they have severe kidney disease with GFR less than 30, they have diabetes with target organ damage more than 3 major risk factors, and these are really very high risk patients, and the LDL will be down to 1.4 and 55%. The 55 milligram per deciliter. Now, if we go to the patient who have recurrent attacks of vascular event while they are taking their maximum tolerated statin based on therapy, or they have polyvascular diseases, they are very high risk patient, and this group should be really their LDL to lower to 1 less than 1. So you can see here we have two really notes here. Your patient should be risk stratified according to his profile. Then you have to put a target, and then you have to select the right treatment to reduce this target. So to reach one is not an easy task. If you want monotherapy, you have to think about always more than one therapy, dual therapy, triple therapy to reach the target that you need. And we know from the different trials that each agent we use have different capacity of reducing the LDL. If we talk about moderate statin like atorvastatin 20 to 40, then you're talking about 30% reduction. High intensity statin between 40 and 80, you're talking about 50% reduction. Ezetimibe by itself is only 20%. Bempedoic acid is 23%. If you take ezetimibe to bempedoic acid, it's 38%, and so on. If you combine high intensity statin plus ezetimibe plus PCSK9 plus bempedoic acid will be reducing down by 86%. So basically, you have to your baseline, and from day one, you have to decide how much I need to reduce it down, whether I can use one agent or two agents or three agents from day one, because you don't waste time really. The earlier reduction, the better the outcome. The earlier we reach the target, the better, and the longer we keep the target, the better. So basically, we're talking about different type of really different medication capacity to reduce the LDL. What about our own guidelines here in the kingdom? We have the published in the HeartView 2023, and you can see here again, very simple, put it forward. They put the very recurrent attack extremely high risk as 1 milligram per deciliter, as we know here, 40 milligram per deciliter or 1 millimole per liter. These are the very high risk patients, the extreme high risk patients. They are really similar to the European guidelines and in this classification, and they put your LDL goal, the non-HDL goal, and ApoB as well goal, so you can use any marker here following these guidelines, this classification, and to put your patient accordingly. Now, what about current data on LDL reduction at patient? Are we really able to reduce the LDL to the target ourselves? And this is really a big question because we are not able to do it, and there are many reasons behind it. We can take two studies, one international study done in Europe, published in the year 2023, and basically they have here looked for patients, among the control of patients with very high risk in Europe between 2021, and it's multi-national observational study. These data were presented in Santorini's trial, an observational trial, documented use of lipid-lowering agent in patients above 18 years old who had high or very high risk between the year 2021 across the primary secondary setting in 14 European countries. So it's a recent study in 14 countries. In this study, they enrolled almost 9,600 patients, and overall, 21% of the patients have no documented over to the lower lipid-lowering therapy, and 54 were receiving monotherapy, unfortunately, and only 24 were receiving combination therapy. The median LDL was 2.2, and only 20.1% of patients achieving the target was put as the one target we mentioned before. So only 20% of patients are the target which have been set by the European guideline itself. So in Europe, only 20% at the target. Our data here from Gulf Action done by Professor Habib and his group, again, have the same data. You can see only 25% here are a target, while 73% are not a target. So locally and internationally, we are too far from the target. And this can explained by the patient compliance, the patient, ability to continue on the therapy, the patient reaction with the news, with media about what's happening on about the statin side effect and their effect on the muscle. Many really barrier to reaching the target. Some of them really relate to the system, to the patient, to the hospital, to the pharmacy supplying the drug for us as well. So in summary, what we can say, we have to prevent first heart attack. This is really important. Normally, we can get patient without this natural history of coronary disease, that the patient get the plaque and the plaque rupture and come with acute event. Many patients will not survive it, first events, and they will really die at the time before they reach the hospital, or they come with massive MI and massive really heart attack that really keep them under really bad rest of their life. We have the second step is really current practice, primary secondary prevention. So we really, based on the risk factors assessment, we can start treatment and then secondary prevention. But if we want to do it right, we have to really start early and prevent the atherosclerosis and prevent plaque progression and prevent secondary prevention and the plaque rupture. The only way to do that is really to go early and detect some clinical atherosclerosis and start early therapy for such patients. Now, really the approach is not really only lipid profile. It should be really a multi-system approach. The patient should have all risk factors under control. We have to control his glycemia, blood pressure, the body weight, and use the medication that really helpful for cardiovascular prevention and prevent kidney disease and prevent really the heart. Stop smoking, use antithrombotic therapy, manage weight, lower the lipid, control the blood pressure, and really start early screening and surveillance. With that, I will stop, Dr. Faisal, and hopefully that will be discussed more in the discussion now, and then I will leave the floor for you now. Dr. Faisal is well known really. He's consultant cardiologist, other cardiologist at Fahd Medical City in Riyadh. He is advanced echocardiographer consultant, as well advanced heart failure and heart failure transplant. We are very proud of him. He's working at King Salman's Heart Center at King Fahd Medical City. Dr. Faisal, please.
Thank you, Prof. Arafa, and it was really interesting to basically learn what you taught us. That unfortunately, so far we are unable to, doing a good job in controlling dyslipidemia in our patients. Basically, today I'm gonna shed some lights on a non-statin therapy used preventing a recurrent event, specifically acute coronary syndrome. So first of all, it is really scary to imagine that if you do have 100 patients with acute coronary syndrome, that the probability of some of these patients will get an event, a recurrent event of acute coronary syndrome, is up to 18%. So if you do have 5 patients in your CCU beds or in your cardiac floor bed presented with acute coronary syndrome, so you can imagine that one of these 5 patients will get an event. And this is really scary. This is not according to me or according to or according to a speculation, rather than it was a well-respected Swedish cohort study, a retrospective cohort of around more than 90,000 patients, showed that the risk of recurrent event is really significant in this patient population. So probably now we do understand how bad is dyslipidemia in this patient population. And the big question is what we can do. Now, unfortunately, before talking about what we can do, if you looked at these patients, especially the one who went for PCI because of acute coronary syndrome event, that only 50% of them achieved an acceptable LDL level according to the guidelines, which we were just taught about. So within 6 months, if you can imagine, only 50% of patients undergoing PCI had an LDL target of less than 70 milligram per deciliter or less than 1.8 millimole per liter. And honestly, in my opinion, and I am 100% sure that you agree with me, that this is not acceptable. Now, what can we do? Of course, we have to optimize their lipid lowering therapy. And the classic teaching that we should start them on a high dose statin and then consider combining ezetimibe, and also for the time being, and as we know from the Saudi guidelines in 2024, and also the European Society of Cardiology recent guideline 2025, that the LDL should be targeted to be less than 50% of the baseline, plus it should be less than 1.4 in these high-risk patients, and in extreme high-risk patient, it should be even less than 1. So this is very important to be kept in mind. And we are not going to talk about all the studies. So we are all familiar with statin and Improve It, which has been published in 2014. They show us the effect of adding ezetimibe to statin therapy. And it's interesting that, we noticed in the market since 2014 that there are different combination of statin with ezetimibe. So nowadays we do have atorvastatin combined with ezetimibe. We do have rosuvastatin combined with ezetimibe. Improve It actually studied adding ezetimibe to simvastatin, but simvastatin is not a potent statin. And if we talk about acute coronary syndrome and these high risk and very high risk patients population, we should use a potent statin, namely atorvastatin or rosuvastatin, and preferably to be combined with the ezetimibe. Now, a 4-year trial, which they studied evolocumab, did show a positive outcome in this patient population. Their patient population mostly were stable atherosclerotic cardiovascular disease patients. And, Odyssey outcome in 2018 studied the effect of alirocumab, which we are going to talk about in the details. I had the pleasure to present previously a similar webinar, the 4-year trial, which did study the evolocumab in patients with atherosclerotic cardiovascular disease, stable atherosclerotic cardiovascular disease. And today we are going to learn about the Odyssey outcome, which they studied the alirocumab. So now we will start with the Odyssey outcome study design. And, the number of patients were impressive. So total number up to 18,000 plus. And they randomized the patients to receive alirocumab plus maximally tolerated statin. And, in the placebo group, they gave them a placebo injection plus the maximally tolerated statin therapy. Now, it is interesting to realize that the study, has been initially intended to be up to 3 to 4 years. However, what they noticed, especially that the study has been designed to be basically an event-determined study. So it is not a fixed duration, rather than it's basically to evaluate the event occurrence. And in this type of study, which has intention to treat, you don't just keep going if you noticed a positive result. So the study duration actually stopped in terms of randomization at 2 to 2.8 years, rather than continue to 3 to 4 years, because they noticed because basically the MACE and the outcome has been achieved earlier than what they expected. And then they continued to follow the eligible patients up to 5 years. So that was impressive. Now, another interesting point when you look at the Odyssey outcomes trial, that 100% of their patient population had a previous MI or unstable angina. So it is not a study of a stable atherosclerotic cardiovascular disease patient. It is really a study of high-risk patient. And this is why probably the MACE has been reduced significantly earlier than what they were expecting. So they had just, because, if you noticed that the result has been achieved earlier and people were getting less ACS as recurrent ACS, then it is unethical just to continue to run the study. And you know that the placebo group are gonna get more MIs and unstable angina. So this is why it has been, concluded with respect to the randomization strategy before 3 years. Also, it is interesting to realize, if you look at the patient population, that around 90% were receiving high-intensity statin, namely atorvastatin 40 or 80, or rosuvastatin 20 or 40. Now, to concur what we just mentioned, most of these patients were having high-risk type of ACS. So most of them were having non-STEMI and STEMI, and the unstable angina were around, 16% and 17% in the placebo group. And, most of these patients, because most of them had non-STEMI and STEMI, underwent revascularization. So really, they are a high-risk cardiac patients. Now, when we talk about the result of the Odyssey outcomes trial, not surprisingly, that the LDL reduction was robust and the LDL reduction was more than 50% when you compare the placebo group with the alirocumab group. Also, it is important to realize, as Dr. Prof. Arafa mentioned, that we should start early in order to prevent the events and the recurrence of that event, that the onset of action basically start early with respect to the alirocumab, and the reduction is robust from the beginning. Now, they started initially with 75 milligram subcutaneous injection twice a week, and then they have been titrating after 2 months to 150 in order to achieve the targeted low LDL but still physiologic LDL. Now, in addition to the significant reduction of the LDL, when we talk about the MACE, which is the major adverse cardiovascular events, it was significantly lowered in the full trial population, and that was lowered by 15%. And the number need to treat was 1, out of 49 patients, to prevent a MACE if these medications has been taken up to 4 years. So it was associated with significant reduction in MACE when you compare alirocumab with the placebo group. And that MACE basically included the fatal and the non-fatal MI, as well as unstable angina and coronary heart disease related mortality. So the composite endpoint of all of these things has been achieved successfully in the alirocumab group, and it was statistically significant. Now, interestingly, if you looked at the higher risk population, when you look at the subpopulation with LDL more than 2.6 millimole per liter, or more than 100 milligram per deciliter, the absolute relative risk reduction was even higher, and the number need to treat is less. So with a treatment of 4 years, you need to treat 16 patients in order to prevent one event, and this is actually an impressive number need to treat, especially in this high-risk population. Now, also another interesting result when you look at the Odyssey outcomes trial is basically the reduction in the all-cause mortality, and that reduction was significant if you looked at the trial population. Now, the p-value was less than 0.05, So the reduction of the all-cause mortality was significant in the alirocumab group compared with the placebo group, despite the use of high-intensity statin in both. Now, the reduction was even higher if you looked at the higher risk population in this group with LDL more than 100 milligram per deciliter. That being said, the interaction p-value was not significant. So in another word, numerically it is more, and the reduction is more. However, probably that higher risk population has not been powered to show a significant reduction. So in theory, in that high risk population, it reduces all-cause mortality significantly. However, it doesn't indicate that these patients are super responder. However, in the overall trial population, there was significant reduction in the all-cause mortality, and the alirocumab in the Odyssey outcomes trial is the only PCSK9 inhibitor which show a reduction of the all-cause mortality. Now, that doesn't indicate the other PCSK9 inhibitor is not associated with mortality reduction. However, if you looked at the Odyssey outcome, one of the beautiful thing about it that they studied the high-risk population. They studied the patients with ACS, and the ACS has been occurred within a median of around 2.5 months before enrollment in the study. So these are our patients as a cardiologist who, or even internist, who basically you see presenting with acute coronary syndrome. So by treating these higher risk population, you would expect that the mortality reduction will be obvious. Now, the 4-year trial basically studied the stable atherosclerotic cardiovascular disease, and this is probably why there was no clear all-cause mortality benefit. That being said, it doesn't indicate that one is more effective than the others. Now, let's also talk about an interesting finding in the Odyssey outcome trial. It is basically the biologic effect of alirocumab. So the PAC-MAN acute MI randomized clinical trial, which has been done in Europe in the well-respected centers, basically studied the effect of alirocumab on the plaque itself. And also they looked at the plaque burden as well as the thickness of the fibrous cap, which is responsible for stabilizing the vulnerable plaque. So this is a very important biologic evidence, and it's so elegant to talk about with respect to alirocumab effect in patients with coronary artery disease. So the baseline characteristic in the PAC-MAN acute MI is not different from the alirocumab group versus placebo. And the change in the LDL, again, as expected, it was robust in the alirocumab group, and it was really impressive that the mean LDL achieved was 0.6 millimole per liter. And the change in the atheroma volume was significant, and this is one of the interesting biologic finding in the PAC-MAN study. So the atheroma, so the volume of the atheroma decreased significantly in the alirocumab group when they measure it with IVUS compared to the high-intensity statin group or the placebo group. Also, when they looked at the lipid core burden index, which tells you how bad is that, of that lipid core in the atheroma itself, and if you looked at the study, they really did it in a very elegant and fancy way, where they measure it with spectroscopy using the near infrared method, and they determine how that atheroma is basically condensed, and that that concentration of the atheroma reduced significantly in the alirocumab group, and the p-value was was statistically significant. Now, what about the change in the fibrous cap? And this is also important to to basically shed the light on, because the fibrous cap is basically the guard of that atheroma from rupture. By having a thick fibrous cap, you basically will get a protected atheroma rather than an atheroma with a thin fibrous cap. So thin fibrous cap atheroma is a vulnerable plaque. So when they looked at the change of the fibrous cap thickening of that atheroma using the OCT, the fibrous cap thickening was significantly higher when compared with the fibrous cap thickening in the placebo group. So the vulnerable plaque has been stabilized and becoming more non-vulnerable, more stable plaque in the alirocumab group compared to the placebo group. Also, a very fancy way to basically measure the inflammation of that lipid core and atheroma is to look at the macrophage angle. So what is the macrophage angle? So basically, the atheroma, when it formed, it is basically formed with a mechanism of inflammation. So inflammation is necessarily to that atheroma, and having more inflammation is going to make that atheroma more vulnerable to rupture. And usually the macrophage in OCT, presents as a shadow. And when they looked at that shadow caused by macrophage, and that atheroma, so the shadow reduced. So basically, the shadow, reduced significantly when basically they compare it to the placebo, which indicate that there was even less inflammatory process in the atheroma and the alirocumab group compared to the placebo group. Now, what about the safety profile? The safety profile has been again, confirmed the previous Odyssey outcome trial, and there was no significant adverse events resulting in discontinuation of the study. And the only downside is as expected, is some sort of general allergic reaction, which was mild in most of the cases, and local injection site reaction. So now we learned that alirocumab is basically a potent advanced lipid lowering therapy, and it caused sustained, significantly low LDL level, as well as it caused a biological evidence to reduce the burden of the atheroma and stabilizing the plaque, in addition to significant reduction of MACE in high-risk population and associated with all-cause mortality reduction. So one of the new advancement of alirocumab, which actually I found it very interesting, is the new development of the 300 milligram once monthly single injection. So in the initial studies of alirocumab, they used the twice monthly 75 milligram or 150 milligram subcutaneous injection, but then they developed and tested the 300 milligram once monthly single injection, which is basically attracting the patients to use it and to have basically this reaction and more compliant. compared to the twice monthly injection of alirocumab. Now, what about the efficacy of once monthly injection compared to the twice monthly injection? Because this is very important for me as a physician to ensure the maintenance of low LDL. This has been studied in the Choice 1 study and in the Sydney study. So if you looked at the Choice 1 study, they basically compared the once monthly injection with placebo, and they looked at the reduction of the LDL at week 48, and also they looked at the secondary endpoints, which is the change in the non-HDL cholesterol, the ApoB, and the Lp(a), as well as the fasting triglycerides. So now let's look at the result. So as expected, the reduction of the LDL, basically, if you looked at the reduction of the LDL and the least square reduction, which is basically the least reduction of the LDL, was around 64% when you compare the alirocumab group to the placebo group. And this was significant reduction, and that reduction has been maintained through the duration of the study, which was 48 weeks. So now looking at the secondary endpoint, there was also significant reduction in the Lp(a) and also the non-HDL cholesterol, the triglyceride, and the ApoB. So it did achieve the primary endpoint by reducing the LDL cholesterol, as well as it was associated with interesting findings for me as a cardiologist by reducing the ApoB and the Lp(a), which are also contributing to the atherosclerotic disease process. So in conclusion, alirocumab is a powerful PCSK9 inhibitor. It is associated with significant reduction in LDL, and also, more importantly, it is associated with sustained reduction of the LDL up to 4 years in the Odyssey outcome trial. It is also a cardiac PCSK9 inhibitor. It is not just a PCSK9 inhibitor for dyslipidemia. It is also a cardiac PCSK9 inhibitor, because if you looked at the patient population of the Odyssey trial, they basically use it in high-risk patients, very high-risk patients, in the cardiac patients, the one who presented with acute coronary syndrome, and it did show clearly all-cause mortality benefits, and it does have, as we just explained, a biological benefit by reducing the volume of the atheroma, stabilizing the plaque, and reduce its burden. And a fancy way of getting an injection is once a month injection rather than twice monthly injection has been developed for alirocumab. Thank you.
Thank you, Dr. Faisal, for the very, very, very impressive talk about the alirocumab role in management of hyperlipidemia. Now we open the floor for discussion. And we have here one question from the audience about which is more really potent LDL reduction. Is it really statin or the PCSK9? So if you'd like to answer this question, Professor Faisal.
Okay, sure. So, of course, PCSK9 inhibitor is associated with more reduction in LDL compared to statin, where the reduction can be basically 50% plus if it is even used alone. But if you looked at the statin, then the reduction is 40%. And I would like to say something, with respect to patients who presented with acute coronary syndrome. Now, sometimes, which is in my opinion not an acceptable practice anymore, when you look at a patient presented with acute coronary syndrome and you looked at the LDL, and let's say that the LDL was 3.5, then anticipating the reduction of the LDL by just using a potent statin, even if you added ezetimibe, is not going to be more than 50%. And your target will be less than 1.4. So your target will be more than around 70 or 80%. So from the get-go, I would recommend to use a potent statin plus ezetimibe and a PCSK9 inhibitor in this patient population. Then, if basically it was reduced significantly, then it is easy basically to stop one of these medication rather than you just increase the probability of event to reoccur, especially that we know that the recurrence can increase in 3 months and significantly increase if you look at the 1 year post event.
Great. So you would recommend for high-risk patient who had already established cardiovascular disease to go for triple therapy from day one if the LDL is very high. While
Yes,
the guidelines say that the way we used to use it, you start high statin, wait for 2 or 4 weeks, and then add azithromycin, and then add. This is really wasting time. And as you said, earlier the better. So the earlier we reduce really the LDL, the better will be the outcome and the maintenance and the plaque regression and the stabilization of the plaque, as you mentioned, will be much better. Now,
absolutely.
yeah.
You know, especially Prof. Arafa, if I am expecting and anticipating that just using statin ezetimibe is not gonna achieve the LDL targets, you know, so this is very important to realize. And let's say that it is probably advised for triple therapy in patients with high risk, you know, atherosclerotic cardiovascular disease. So in patients with ACS rather than in stable patients. Stable patients, you may wait and see, but in high-risk patients, I would say triple therapy for sure.
Great. Now, many people nowadays, they hear about the side effect of statin, muscle ache, muscle pain, and the inability to use higher dose, even different kind of really statin. We have problem with the patient profile. I can see it very common, and unfortunately. So in your practice, Dr. Faisal, how common you find this statin intolerance, and what's the best way really to treat statin intolerance?
Okay, so you know, this is a very good question. Now, what I would say, we have to be careful when the patient say, I have muscle ache. Why? Not because it is related to the statin, rather than muscle ache is a very common complaint. And sometimes it is kind of a placebo effect. Patient gets statin, she or he go and read about it, then he start to feel muscle pain, or he had or she had a bad day, started to feel ache, and said, oh, you know what, it is the statin, it should be the statin, and then they come to you. So you have to be careful when you evaluate the statin induced myalgia. Now if there is a muscle pain and rise in the and rise in the CK, then it is probably a clear shot that this is most likely a statin-induced myositis. But when we talk about just muscle pain, then we have to make sure that it is related to statin. And then if we think it is related to the statin, then one way to do is to give them a drug holiday. And if that muscle ache disappear, then it is probably the cause of the muscle pain and ache.
Great. Now, many people say that I am at the target. Why should continue my own statin or any PCSK9 injectable? I mean, I am on the target now. I'm fine, and have no more chest pain, and I'm doing my job. Why should I continue for statin, and how long should I continue for it?
Okay, so also, this is a very common question, not only for patients with acute coronary syndrome, rather than even with patients at high risk, even the diabetic and the hypertensive, who we just started them on statin. So what I usually tell them that that atherosclerosis is a silent disease. When it comes and knock on your door, it's gonna knock it with a stroke. It's gonna knock it with a heart attack. It's not gonna take your permission to give you heart attack. So when we say that we have to manage your dyslipidemia, it is kind of an investment rather than it is just a hit and go treatment strategy. So you have to invest in your health with respect to dyslipidemia. And it is a chronic disease and it is related to a biological changes. If we stopped that medication, then the only option that you should get younger and you should get without a heart attack. If you could go back in the past and make this happen, then yeah, we can stop the statin. Otherwise, if you cannot get younger, if you cannot reverse your biology, then you have to take a substitute, which is basically the statin and the other lipid lowering therapy if needed.
Great. So if you are a target now and you're taking, say, Bruluent injectable form 300 milligram once a month, and you are on ezetimibe or ezetrol 10 milligram, and you're taking as well, let's say, rosuvastatin of 20. How you would start to reduce it if you want to cut down the medicine? Which you prefer? To go ongoing with the statin 20 milligram, or you stop the ezetimibe, or you want to continue with, how you would say, I would reduce the dose a little bit because the patient now is the target, and we can reduce the side effect. Which one you would start with and why?
Okay, so basically in a very high risk patients, I don't
Great,
reduce the
great,
medication. When we
excellent.
talk about the very high risk patient, no, I don't.
Yeah,
Because still we do have evidence that statin is associated with plaque stabilization, and also it does have an anti-inflammatory effect. And one of, as you know, Prof. Arafa, one of the main theory of atherosclerosis is basically inflammation. This is why they have been studying the other monoclonal antibodies to reduce that inflammation, and the role of colchicine, which has been, the new kid in the block in treating these patients. So no, I wouldn't stop the statin. Now maybe I would stop ezetimibe if it is an additional pill. But if the ezetimibe has been combined with the statin, then probably, I would just continue the statin and the ezetimibe and the PCSK9 inhibitor.
great. Thank you very much indeed. Thank you. Now, regarding the different statins and the intolerance, did you find in that shifting from rosuvastatin to atrova to pitavastatin to, we talk about now moderate risk patient, not very high risk patient, or risk or extremely risk patient. If the patient is moderately moderate risk and he's on a statin, has some intolerance, do you find that there is some difference between different statin in if you want to challenge them? And what about the daily? Some people say, why not I take it every other day? Does it really work?
Now, every other day, again, no, it doesn't work with me.
Yeah,
I usually ask them just to take it daily, and
right,
I just
right,
tell them, the studies which did show benefit, they didn't do that.
right.
So rather, yeah, so basically they have to take it daily. This is number one. Number two, with respect to your first question about the different type of statin, yeah, so simvastatin, fluvastatin are weaker, and sometimes I basically use them in patient who does have complaint of some sort of statin intolerance, but I have to make sure that I do achieve their LDL target. If no, I couldn't, or they developed again complications related to these weaker statins, then I basically go to the advanced lipid lowering therapy by choosing PCSK9 inhibitors, one of them, or inclisiran.
Great, great. Now we still have a couple of minutes. Don't have any question from the audience, but I would like really to have an opportunity to ask you about take-home message, 2 or 3 take-home message that you would recommend for our patient, for our physician who are with us here on the line. We have more than 100 now on the line. So what are the take-home messages that you take to say to them that you have to take it tonight and apply it tomorrow?
Okay, so when we talk about take-home message, Prof. Arafa, probably it is very clear for you, it is very clear for me, it is very clear for everyone that despite that we do have the knowledge, despite that we do read the guidelines, despite that we hear it every day, despite that we attending conferences, we go through different webinars, we do not do a good job so far. Yet we do not achieve the LDL target. So please make sure when you start the statin, don't starting a statin or ezetimibe just to treat yourself rather than you have to treat the patients. And you are not treating the patient unless you look at the LDL target, and do not hesitate to start an advanced lipid lowering therapy, one of the PCSK9 inhibitors, if you did not achieve the LDL target. So I think this is the main take home message. Everyone knows about the risk of having LDL in this patient population, but still we have to be conscious that we need to look at the target, not just starting the medication.
Great stuff. So the earlier the better, the longer the better, and the lower the better.
Absolutely.
So if we have to really achieve an early reduction, maintain it, and for long time. It's not really a matter of weeks or months, it's a matter of years. And even if your family physician or if your friends say, why you are still taking medicine, tell them that I don't want to have another heart attack, because to have a second heart attack is really more lethal than the first one. So be careful not to stop medication without really good reason for it.
100%.
Thank you very much, Dr. Faisal. Thank you, the Saudi Heart and the Close Research for their support for this meeting. And thank you, Sanofi, for your support. And hopefully we'll see you another episode of this program. Thank you very much.
Thank you for you, and thank you for everyone for being with us. Thank you again.